Okay, yes. So my name is Thalén. I'm a physician scientist. I'm doing my medical residency at Karolinska in clinical physiology. And clinical physiology is a medical specialty that only exists in Scandinavia, basically. So we live sort of in a space right between cardiology and radiology. We do a lot of diagnostic testing. We do a lot of echo, ECG, CMR, SPECT. We also do pulmonary function testing and cardiopulmonary exercise testing. So if a cardiologist asks me, I say that I'm a diagnostic cardiologist. If a radiologist asks me, I say that I'm a cardiovascular radiologist. So it's sort of in between, but we do a lot of diagnostics. I just wanted to clarify that. Yes. Okay. So I just wanted to show off my beautiful home that I'm missing. Karolinska Institute and Karolinska University Hospital and Stanford University, where I am right now. Okay, so an outline of my talk. I'm going to talk a little bit about lupus. I'm going to talk about cardiovascular risk in lupus. I'm going to talk about some of the research that we've done with selected CMR methods for cardiovascular phenotyping. And I'm going to talk about specifically CMR in lupus. And these will be my take-home messages, that cardiovascular risk is increased in lupus, that not all chest pain in lupus is pericarditis. Now it would have been good to have the rheumatologist. I'm going to talk about our study that stress perfusion is reduced in lupus without chest pain. And hopefully I'm going to demonstrate that CMR can be useful in the diagnostic workup of lupus with chest pain. So lupus erythematosus. Lupus is Latin for wolf, originally used to describe any skin lesion resembling a wolf's bite. And erythematosus, Greek for redness. And just briefly, some of the milestones in lupus history then. In the classical era, lupus was used as a description of any destructive skin ulcer. 1851, the lupus erythematosus was coined for a discoid facial rash. 1872, lupus was labeled a chronic disease, so now people are starting to get it. And during the 1870s, the systemic form with fever, arthritis, and the butterfly rash was identified. And in 1895, the actual word that we use now, the name systemic lupus erythematosus, was coined, and multi-organ involvement and relapses were documented. In the 1920s, saw pathological studies that showed kidney, heart, and lung damage. 1948 is a milestone with the discovery of the lupus erythematosus cell, or the LE cell, which is a lymphocyte that has phagocytized some nuclear material. And the 1950s brought about corticosteroids, which I've highlighted in red here because it is a very effective treatment. And during the 1970s, 80s, and beginning of 2000 saw a redefinition of the classification criteria, which now include both clinical and immunologic. And of course, in the modern era, we've had immunosuppressant, biologics, and disease-modifying drugs. Yeah, so the epidemiology and burden then. So about 42 to 300 cases per 100,000 individuals in the US. It's very heterogeneous across countries and ethnicities. The all-cause mortality is increased 2.6-fold, and there's a 9-to-1 ratio of female to male patients. And it's called the disease of 1,000 faces because it's so heterogeneous. It can involve any organ. Yes. And so the classification rests on the European Alliance of Associations for Rheumatology and American College of Rheumatology. The latest is the 2019 EULAR ACR criteria for lupus, and this is a significant work because the group is so heterogeneous. And so the entry criteria right now is a positive anti-nuclear antigen test, and then there are 7 clinical criteria and 3 immunological criteria, which score different points. So I'm going to just quickly do a 1-minute lupus pathophysiology. It all starts with apoptotic debris, which is usually nuclear material resulting from apoptosis of some cells. Macrophage shows up, phagocytizes the apoptotic debris. T cell comes along. Macrophage shows the apoptotic debris to the T cell through the MHC molecule. T cell talks to the B cell, tells the B cell to start producing autoantibodies. Autoantibodies go out into circulation, encounter more apoptotic debris, form an immune complex. And the immune complex is deposited into different organs. Here I've just chosen kidney, heart, a joint, and a brain, but it can really be any organ. Immune complexes are deposited, cytokines and complement factors are released, causing inflammation. So it's been known since the 70s that mortality in lupus follows a bimodal pattern, which means that those who die early usually die with active lupus and have a remarkable incidence of infection, and those who die late die with inactive lupus and have a remarkable incidence of myocardial infarction. This is one landmark study from 1997 showing the incidence of cardiovascular events in different age groups. Can you see my mouse pointer, by the way? Okay, great. And in the different age groups, and we have the lupus patients and the Framingham offspring heart study, and we can see that the rate of cardiovascular events is much higher for myocardial infarction is much higher in the lupus group, specifically 50 times higher in this age group 35 to 44 here, which is quite remarkable. We can look at another study from 2003 showing in this figure we see the prevalence of coronary artery calcification in these different age groups for patients with lupus compared to controls, and we see that the patient with lupus in all age groups have a higher prevalence of coronary artery calcification. But as you know, the devil is often in the details. So if we study the table 1 of the clinical characteristics of this study, we see that there are a few significant differences between the patients and controls. The lupus patients smoke more, they have more hypertension and higher triglycerides. So one could argue that, well, this increase in coronary artery calcification is due to an increase in traditional risk factors rather than actual lupus. But it has been shown that that is not the case. So this is a study from 2001 showing the relative risk of vascular outcomes in lupus compared to those expected based on the Framingham models. So in this left column we have outcomes, non-fatal myocardial infarction, death due to coronary heart disease, overall coronary heart disease, and stroke. Here we have the observed number of events in the lupus cohort, and here we have the expected number of events based on those patients' risk factors. And we can see that the observed to expected ratio is quite high. So there's something about lupus that goes beyond traditional risk factors. And what is it? Well, there are several proposed mechanisms driving cardiovascular risk in lupus. One of them is inflammation leading to accelerated atherosclerosis. There's also been a lot of discussions around corticosteroid use, which remains somewhat controversial, if that causes an accelerated atherosclerosis or not. And there's also endothelial injury. And there are many, many more. So I'm not going to spend so much time here. So I'm also briefly going to talk about lupus, pericarditis, and effusion. 36% of lupus patients will have had pericarditis, 26% will have had pericardial effusion, 9% a hemodynamically significant effusion that requires pericardiocentesis, and 3.2 will develop a cardiac tamponade. So in here we see a CMR 4-chamber cine of a patient with a pericardial effusion. I'm going to talk briefly about this study from 2004 that showed that the number of CD146 positive cells per milliliter, so this is On the vertical axis, we have the number of apoptotic endothelial cells in circulation in the blood is much larger in the lupus cohort. So they have much more circulating endothelial cells compared to controls. And interestingly, there is no difference between the controls and patients with coronary artery disease. So something is going on with the endothelial cells in this group. And I just briefly want to mention the coronary microcirculation. So we know that the spatial resolution of an invasive cardioangiogram is too low to appreciate the coronary microcirculation. So this image is taken from this is not something you can do invasively. This is a specimen, and you can sort of appreciate how the dense network of prearterioles and arterioles in the left ventricle and the right ventricle for that matter. So there is much more going on than we can see with an invasive coronary angiogram. Which brings me to coronary microvascular dysfunction, which is sort of like a shift in the paradigm and how we think about coronary artery disease. So the definition is an abnormal dilatation and constriction of the small blood vessels in the heart. So here the problem would be in the coronary microvasculature instead of in the coronary artery. And so which brings me to qualitative CMR first pass myocardial perfusion. In this image is a method that's been around for quite some time. We see the injected bolus of contrast coming into the right ventricle, the left ventricle, and finally the myocardium, and we can appreciate this large perfusion defect in the lateral wall. And this has been studied in lupus patients. So in this study from 2011, they performed this qualitative myocardial perfusion in 20 female lupus patients with symptoms of angina. So these were symptomatic patients. And of these 20, they found 8 that had perfusion defects. Yet most of them did not have any coronary CTA findings, which is interesting. And this has also been studied quantitatively using myocardial perfusion PET. This is a study from 2021. And on the horizontal axis here, we have the myocardial flow reserve, which is defined as the stress myocardial blood flow divided by the rest myocardial blood flow. So it's a measure of how well your microvasculature can dilate and accommodate this increase in perfusion that is required during stress. And we see that the lupus patients have a lower myocardial flow reserve compared to the controls. They also could calculate the coronary artery calcification score in these patients, and they could show that the lupus patients and controls had similar coronary artery calcification scores, which points in the direction of coronary microvascular dysfunction as opposed to coronary artery disease. So I just want to take a moment and reflect upon what the difference is between qualitative and quantitative myocardial stress perfusion. Here on the left we see the image that I showed earlier, and here on the right we have a quantitative stress myocardial perfusion study. This is performed using the method developed by Dr. Peter Kalman and his group at the NIH. And we can appreciate the perfusion defect in the lateral wall, but we can also measure on a per pixel basis the perfusion in actual milliliters per minute per gram in the myocardium. So that enables a description of diffuse pathology as opposed to focal pathology. I should say as well as focal pathology. and this has been studied. This is a study from 2020 showing that the event-free survival is different between those that have a stress myocardial blood flow above 2 milliliter per gram per minute compared to those below 1.99 milliliters per gram per minute. And now I'm going to continue by talking a little bit about our own research. We've studied the hemodynamics that occurred during respiration. So in this upper plot we see the lung volume with the inspiration and expiration marked, and the bottom rows show mitral flow velocities and tricuspid flow velocities. And this is to illustrate the fact that during inspiration, the venous return to the left heart decreases, whereas the venous return to the right heart increases, and vice versa during expiration. And why is this relevant? Well, I discussed pericardial effusion before, and during a hemodynamically significant pericardial effusion, this effect becomes much more pronounced. So we developed a method where we could use a 2D phase contrast sequence that is real time. So during 30 seconds of free breathing, this just shows how the slice was prescribed in the atrioventricular plane. Here are the resultant magnitude image and the phase image, and in the phase image we actually have encoded velocity on a per pixel basis. Now I segmented the mitral orifice and the tricuspid orifice, and I developed this method that I'm going to walk through now. Here's a patient. We see the results of a patient without constrictive physiology. In this top plot we have mitral inflow velocity with velocity against time, 30 seconds of free breathing. We see the characteristic early filling and atrial filling, the E and A waves. The software has identified the peak E velocities, found the maximum and the minimum, and calculated the respiratory variation in these inflow velocities. And we can see that this patient who did not have any constrictive physiology had a respiratory variation of 18% for mitral inflow and 30% for the tricuspid inflow. And in this bottom plot we see respiration by lung diaphragm interface M mode to be able to track the breathing of the patient. And here we have a patient that has constrictive pericarditis, which shows a 60% respiratory variation in mitral inflow and 44% tricuspid inflow. And a patient with 35 millimeter pericardial effusion that show a 62% respiratory variation in mitral inflow and 64% in tricuspid inflow. So we weren't able to image that many patients, but we did develop normal values for respiratory variation in transvalvular velocities by CMR. And we found the normal upper limit for mitral respiratory variation to be 34% and the upper normal limit for tricuspid respiratory variation in tricuspid inflow velocities to be 60%. We also performed some T1 mapping in the actual effusion fluid. So we had 111 patients, and in this image we see 3 T1 maps taken native, that is before the injection of contrast, early, and which is around 3 minutes usually, and late, which is up to 20 minutes after contrast injection. These are T1 maps, and they're all windowed to the same scale. This patient has a pericardial effusion here, where I've segmented using a white region of interest, and a pleural effusion, which I've segmented using a dark region of interest. And then we can follow the contrast. We can measure the T1 in the pericardial effusion and pleural effusion, and follow the contrast in this space. And we found that native T1 here on the vertical axis differs between the pericardial and pleural effusions. Perhaps not surprising, these are two different fluids after all. We also looked at the contrast dynamics. So we have the pre-contrast native T1 early, 3 minutes after, and late after contrast administration. And we see the T1, and we see that for pericardial effusions and pleural effusions, contrast is distributed into these effusion fluids, as evidenced by the fact that we do not have any horizontal lines or lines slanting upward. We also went a little bit further and made this quotient delta R1 early to delta R1 late, and the delta R1 is the actual variable that is directly proportional to the gadolinium contrast. So delta R1 reflects gadolinium concentration, and we made this quotient because it is now an effusion volume independent measure of early to late contrast. And we see that this is different between pericardial and pleural effusions. So this is not my work, it's the work coming out of London in 2021. They managed to show that T1 values here on the vertical axis in pericardial and pleural effusions differ between exudates and transudates. So this means that we are able to use actually T1 mapping to separate exudates from transudates. And exudates, if you remember, is the inflammatory type of fluid, whereas transudate is more of a clear liquid, more due to osmotic rather than inflammatory effects. So this is work from our group where we set about to procure normal values for T1 in pericardial fluid. So in 30 healthy volunteers, I measured the T1 in a pocket of pericardial fluids. Now we wanted the measurement to be reliable, so we said that, okay, so the region of interest size needs to be between 10 to 50 square millimeters. The coefficient of variation of T1 within each region of interest should be below 10%. The relative difference in T1 between a short axis and a perpendicular slice should be below 5%. So in this image we see a short axis, we see a pocket of pericardial, I should not say effusion, but pericardial fluid. This is in a healthy volunteer, and then we see the perpendicular slice that was prescribed to show the same pocket of pericardial fluid in the same person. And we found that a reliable measurement was possible in 87% of the volunteers, and that the native T1 of pericardial fluid at 1.5 Tesla was 3,262 plus minus 163 milliseconds with these normal limits. And now we come to quantitative myocardial perfusion in lupus. This is a study we performed in a lupus cohort at Karolinska. So we had 23 patients with lupus and 25 controls. We have stress perfusion here, so the stress myocardial blood flow, or MBF, in milliliters per minute per gram. And we see that the lupus patients have a lower stress perfusion than the controls. And if we superimpose this proposed cutoff that's been proposed in 2019 for diagnosis of microvascular dysfunction, we see that a few of these patients actually meet the criteria for that. But these are asymptomatic patients. We also had a more clinical study where patients who were complaining to their rheumatologist about chest pain were referred for CMR, and this graph shows the prevalence of findings here. We found 21% coronary artery disease, 21% coronary microvascular dysfunction, and 16% pericarditis. So these are CMR. This is CMR in lupus patients with chest pain. So why CMR in lupus patients with chest pain? How can it be useful? And now I've come to the interactive case part. So we'll start by this. We see here basal, mid, and apical views of late gadolinium enhancement. We see stress perfusion, and we see rest perfusion. Would anyone like to venture an interpretation? Yeah, this is a little bit tricky, and I didn't give you the opportunity to measure. These are actually normal CMR findings, so a little warm-up. Yeah, but it is difficult to gauge without having the ability to draw and segment, of course, which ideally you would have. So we move on. This again, we see basal, mid, and apical. I've left out the late gadolinium enhancement. We see stress and rest. Does anyone see anything interesting? Yes. That is correct. So this is coronary microvascular disease, and we see that the stress perfusion is lowered in all segments, and we have this gradient going from the epi to the endocardium. Yes. Now this is a case from our own. This is an actual lupus patient at Karolinska. Again, we have basal, mid, and apical slices, late gadolinium enhancement, stress, and rest. Would anyone like to interpret? Yes. Thank you, Marcus. You are absolutely correct. This is, in fact, an infarct and three-vessel disease. Thank you very much. And then we have the last case here. We see we have late gadolinium enhancement in basal, mid, and apical slices. And I've also included the T1, the ECV, and the T2 in basal slice orientation. And I can give you the quantitative measurements. So does anybody see anything interesting? Yes, it's 3 Tesla. Yes, I should have said when I gave the quantitative measurements. Yes, thank you. This is a case of pericarditis. This is again a case from Karolinska. We see the pericardial thickening and pericardial hyperenhancement here after late gadolinium imaging. And as Dr. Carlson said, it's very useful to have the T1 maps and the T2 maps because fat has a low T1, so this is not consistent with fat, but with pericardial thickening and hyperenhancement. And why did I include these? There's another reason why I included these T1 ECV and T2 maps, and that is because we can use this to look at the 2018 Lake-Louise criteria for myocarditis, which also occurs in lupus patients. And of course, they can occur together in perimyocarditis, right? But in this case, we can rule out myocarditis because the T1 and ECV and T2 are normal. So, okay, I've talked about lupus. I've talked about some selected CMR methods for cardiovascular phenotyping. I've talked about CMR in lupus. And I hope that I've convinced you that cardiovascular risk is increased in lupus and that not all chest pain in lupus is pericarditis. That is important because there could be a slight cognitive bias since pericarditis is part of the clinical criteria for SLE, so it's easy to think in the setting of lupus. And I've shown that stress perfusion is reduced in lupus patients without chest pain and that CMR can be useful in the diagnostic workup of lupus with chest pain. And I'd like to acknowledge my awesome teams, both at Karolinska and at Stanford. And with that, I would like to open up the floor for questions. And thank you for your attention.